All right. Good evening, everyone, and welcome. I'm Abby Skaggs, delighted to kick off today's webinar. As a part of the colorectal marketing team at Intuitive, it's my pleasure to collaborate with our esteemed guest speakers who are bringing you a great presentation tonight. But before we dive into the content ahead, let's set the stage. A few weeks ago, you may have joined us at Connect 2024 in Las Vegas for Dr. Marinez's captivating live stream of his minimally invasive Da Vinci LAR case. It was quite the gripping case, if you remember. The complexity of the case exceeded his original expectations, leaving us all eager for more. Today, we're here to bring you the rest of the story. Dr. Marinez will share video and insights from the second half of the case that was not shown at Connect. And for those of you who we missed at Connect, not to worry, because we're thrilled to have you here now and we'll catch you up to speed. So without further ado, I'm honored to introduce our distinguished speakers today, Dr. Diego Marinez from Houston Methodist and Dr. Mark Soliman from Advent Health.
Great, thanks Abby for the stage. It's really great to see everyone tonight. We are monitoring the chat on Surgeon, so don't be shy to ask questions there. We're going to try to make tonight as interactive and as dynamic as possible. So we want to keep it like we did in Vegas. We want to keep this as collaborative and engaging as possible. Let's go to the next slide here. As Abby kind of mentioned, the context of what we're doing tonight is it really originated in Vegas when Diego was doing a very unfortunately difficult case in front of a group of almost 200 surgeons. And at the time, he was doing it using Intuitive Hub, which is actually what's on screen right now. So Intuitive Hub, for you guys that don't know, basically, Intuitive Hub is Intuitive's installed system that allows and enables remote case observations and surgical telepresence. And so the system gets installed in the operating room, and then we were in Vegas watching it through a web stream. So let's go to the next slide. And then effectively what's happening is that Diego's on the console on the left. We're all in Vegas on the right here, watching the entire live stream. And what ended up happening is, again, as Abby alluded to, is the case was very, very difficult. And we'll cover the case in just a moment. But it was actually somebody from the audience, Dr. Jorge Lugares, which I consider a friend and mentor of mine, that actually gave a tip to Diego that actually helped him progress in the case. And that's really the context and the background of what we want to do. So with that said, the housekeeping for tonight is we want this as engaging and as dynamic as humanly possible. So do not be shy to put stuff in the chat on Surgeon. We will be watching the chat and monitoring it throughout the entirety of the evening. With all that said, now I'm going to step over and introduce my good friend, Dr. Diego Marinez. So Diego is the director of colorectal surgery at Houston Methodist at Willbrook Hospital in Houston, Texas. He's the chair of an enhanced recovery program at Houston Methodist Hospital System, which has a goal to provide a smooth recovery with quicker return after daily activities for patients undergoing surgery within the 8 hospitals in the Houston market. He holds an active teaching position as an adjunct assistant professor within Texas A&M Medical School, and he's clinical faculty for the general surgery program. He's also, and this is probably the first thing we should have said, he's a chief of surgery at his institution. So Diego's a good man, a good friend, and just a phenomenal surgeon. So we want to welcome Diego to the virtual stage, and let's kick this thing off. So Diego, how's it going tonight, man?
Great. Wow, thanks for the warm introduction, Mark. I didn't know you liked me, but no, I'm kidding. But
Dude, you're the man.
This is exciting to be able to show. We're going to show part of the, or almost the entire surgery that we showed in Vegas, and then we're going to show the rest of the story that we didn't have time to stream live.
Perfect. Diego, let me just at the start. And now if we're ready to switch the streams over, so Diego, you want to start sharing your screen. Let me ask you, as this is coming up, tell us a little bit about the patient real fast. Let's set the stage for us clinically.
Yeah, so this is a 53-year-old man with not a lot of medical problems that he reported on his office visit. And you'll find out in a minute why I say it this way. That he was having some obstructive symptoms, some bloating, a little bit of diarrhea, intermittent with constipation, and he got a attempted colonoscopy by a GI colleague, and he could not pass the mass that he found in the proximal rectum at about 12 to 15 centimeters from the anal verge, malignant appearing, near obstructing mass that he biopsied and was adenocarcinoma. So of course we staged this mass with an MRI of the pelvis with a specialized rectal protocol, a CT scan of the chest, abdomen, and pelvis with IV contrast, blood work. And long story short, on the staging, the MRI showed a large mass measuring about 7 centimeters with some mesocolic lymph nodes that were suspicious for them being malignant. But it was all intraperitoneal. So everything was above the peritoneal reflection. And we presented at a multidisciplinary meeting, and we decided to go with upfront surgery.
Got it. So I watched the video. I just assumed he got like hammered with radiation.
It looks like
so
a
there was
radiation.
no, geez, oh my God. Okay. And no prostate cancer, no previous pelvic radiation, nothing like that, right?
Nothing like that.
All right. Good God. All right. So, all right, man. So what's next? Talk us through the next steps here.
Yes. So let me start sharing my video and just take a quick minute to mention how Intuitive Hub is being very helpful for our teaching and for our education. Like you mentioned, we have hubs in the OR, and someone can be observing the cases remotely. And we've been very active with remote case observations with surgeons from all over the world, actually. I'm sure you have too. We've had a group of surgeons from India observing multiple cases over here, and they can interact with us live. We can discuss the case as we go, and they can have a view of the room, and they can have a view of the intra-abdominal case. But let me tell you a little bit about the port placement that I'm doing. I'm going left upper quadrant to right lower quadrant. And then all this is before we started live streaming. So my goal was to put the ports in, get the lay of the land first, and just be ready to go with a medial to lateral dissection when we started streaming live to Vegas. So, of course, when we introduced the laparoscope, we realized that the liver appeared cirrhotic, as you guys could see on the video, and that was unexpected. So that's when I started saying, well, this is going to be interesting.
Yeah, just seeing this mesenteric foreshortening. But what was going? I want to kind of get in your head a little bit. I mean, as this is playing, what's going through your mind at this point? You got 200 people in your ear. We're watching you, and actually, I physically wasn't there, but what was going through your mind? The emotion of the surgeon, if you don't mind me asking, because that's a real piece that we don't really talk about.
Right. So before we started live streaming, I was lysing some adhesions here laterally, and I was just thinking how this was going to be much more difficult than I expected. And I felt a little bit of responsibility to finish the case in the time we had, because we had 2 hours or an hour and 45 minutes to stream. And I had predicted that it was going to take me less than 90 minutes to do the case. And I wanted to show, anastomosis. I wanted to show distal division of the rectum, all those important steps that I'm sure the audience wanted to see. And right now I was thinking I might not be able to show all those things. So actually it was great that we have this opportunity now to go through all those things that we could not show that day.
Yeah, got it. Yeah, and I wasn't personally there. I was actually I was back home at a hospital obligation, but I was getting texts during the video like, "Oh my God, this looks like a terrible case. I would hate to be Diego right now." Is what was the messages. So anyway, kudos to you. So tell us a little bit about these. You know, these are thick attachments. So talk us through kind of how you're walking through this right now. Like what's your methodology, I think, during this part of the case?
My approach for upper rectal or sigmoid cancers is I like to approach it medial to lateral, but I feel that if we first lyse these adhesions laterally and kind of restore the anatomy of the sigmoid, we can then put adequate traction up on the sigmoid and expose the area of the IMA pedicle better. So that's why I'm doing these adhesions laterally. So here I'm thinking, well, I don't want to do too much, before we start streaming live to connect, but I want to just have it all ready to go.
Yeah. So quick question. Shrey Moody in the chat is asking a really good question, actually. You know, the guy had lymphadenopathy. Why not do a decompressive loop colostomy or ileostomy and then give neoadjuvant chemo instead of upfront surgery?
Mhm. No, and that's a good thought. I mean, in retrospect, that could have been a viable option. Still, I think the recommendation for a fully intraperitoneal tumor above the peritoneal reflection is to just do the surgery up front on most tumor boards that have been involved.
Yeah, I agree. I mean, you know, really, if the lymph node basin is going to be completely resected at the index operation, Shrey, and typically we'll just kind of take it all out. But if it exceeds the typical lymphadenectomy site, then that's when we would definitely want to send for neoadjuvant chemotherapy. But there's a fantastic point. I mean, we're doing this more and more commonly now for like right colon cancers and you know, just those more, you know, things that you're not typically going to do an extended lymphadenectomy to get to.
Right.
So talk us through here. So you're digging this thing out. You're shoveling
So
the descending sigmoid colon over.
yeah, so here we just started live streaming. So now everyone's watching this in Vegas. I'm giving them the lay of the land again, and I'm about to start the medial to lateral dissection. And I'm trying to decide whether to go right there where I decided to go, or a little bit more towards the right side. Like I want to say more proximal on the pedicle,
Yeah.
where the tissues were a little bit more indurated.
Yeah.
So here I'm I dissect and I start scoring the peritoneum all the way to the peritoneal reflection. And
Is that your typical approach? Sorry to interrupt. Is that your typical approach where you go, you score laterally and then you or rather medially, and then you score around the interperitoneal reflection? Is that typical?
yes, I do, and I all the way around
Okay.
laterally to where I'm gonna free it up from the lateral part too.
Got it.
But usually it gets, you find areolar planes, you find avascular planes. You can do a lot of blunt. And here I'm having to go very, very slowly because it just looks like it wants to bleed. So
let me ask Diego, like, how do you normally, when you do this dissection, how do you normally identify your entry point for the medial dissection? So meaning, like, you made the decision to go where you did, which that's exactly probably where I would have gone. How do you make that decision at the time? Is it by texture? Is it by feel? Is it you're kind of just guessing? Well, talk us through that.
yeah, what's going on through my mind when I decide where to start the medial to lateral is, okay, I tented up the IMA. Sometimes if the patient is not too obese or doesn't have a lot of disease, like in this case, we can see the IMA, the pulsatile vessel right there. And then we can follow it down towards the right side, and we can see the right iliac artery also pulsating. And then I try to go maybe, 2 or 3 centimeters above the right iliac. I don't want to be that close to it. And then I start scoring horizontally. where I know there aren't any named vessels. So that's going to be my plane.
So basically just to the left, essentially, of the iliacs on the right hand side. So
Yes.
medial to them. Got it. Got it. That's like the emoji that just popped up. Yeah. Got it. So now you try to go medial, struggled, and now you're going lateral now.
Yes, and you can tell that I would have kept going medially. I'm like you. I watch my own videos and I always try to be more and more efficient. And one of the things that I have identified is that I need to, if I'm starting a medial to lateral dissection, I want to finish the whole medial to lateral dissection before I go to any other approach, because then you're just wandering around, right? So you want to avoid that, you save time. But I was hitting some points on the medial to lateral dissection that were starting to get a little risky for bleeding. And of course, I didn't want to have a lot of bleeding in this case, because then it would obscure everything and we couldn't show much. So I said, okay, let's try to find the ureter laterally here instead of medially.
Got it. Yeah, and honestly, this is perfect. Exactly like you said. It's like you're not making progress one direction. You can't just keep piddling around that area. You got to do something to make progress. So yeah, 100% going the opposite.
Yeah,
That's
absolutely.
perfect. So that's your typical try to make progress immediately. You can't go, then you go laterally.
Yes, yes. Do you start medially too?
Yeah, I actually do just like this in that I'll always do my best to restore the anatomy so that I can pull the rectosigmoid up. And then only once I pull the rectosigmoid up, then I go medially. And so it's not a lateral dissection. It's just restoring the anatomy exactly as you did. And then just like you did, then I go medially. I mean, and exactly as you did. If I had trouble with the medial dissection, the only difference I probably would have done is I probably would have hopped up to the IMV, identified the sub IMV plane, and then worked my way down to the IMA. And I find that that's kind of been my more recent choreography prior to going lateral. But I mean, I'll do the same thing. Kind of go medial, sub IMA, medial, infra IMV. If that doesn't work, then I'm going to go lateral to medial. So just like kind of like this.
Yeah, that's a good point. I do that, but only when I'm going to mobilize the splenic flexure, which in this case, it looked like the sigmoid was super redundant. That was another thing that made it challenging for the dissection, even though it was going to be helpful to make a tension-free anastomosis. Sometimes those very, very redundant sigmoids flop all over the place, and it is challenging to dissect. Yeah, I'll keep that in mind for even if when I'm not going to mobilize the splenic flexure, you can always start at the sub IMV.
Awesome. All right, so talk us through where you're at now.
Yeah, so here we're still live streaming. I'm trying to find the ureter laterally because, once I was thinking, once I find the ureter, I'm going to be able to go much more expeditiously here on the dissection. We could not do it medially, so here we're just working. And here we can talk a little bit about identification of the left ureter on a lateral to medial plane.
Yeah, please.
Yeah, so here I'm identifying that the yellow fat that I'm leaving on the left side of the screen is mesenteric fat because it's a little bit brighter, right? And everything else on the right side is it looks like either a retroperitoneal structure like gonadal vessels or psoas tendon or pale yellow retroperitoneal fat. So that's the plane I'm trying to find. And here I know that we're close to finding the ureter because the gonadals are not far away. So here I'm just dividing that tissue on top of what I think is the ureter. So let's see if we can find it here. I think that's it, but we're gonna make sure it vermiculates and that we're 100% sure that's the ureter before we go faster down into the pelvis.
And Diego, just for some context for the audience, you lightly edited the video, and it's what speed is it playing at right now?
It is playing at
2x, is it?
Yeah.
Okay, all right, great.
Playing at
And
2x.
just for everyone,
Go ahead.
Sorry, please go.
Yeah, and I pretty much only removed the camera cleaning parts and the instrument exchange parts. That way, we have it all here, and we can always fast forward a little bit here once we identify the ureter.
Got it. All right, so I want to get in your head a little bit. You're 200 people are watching you do this. You're struggling. You're making some progress. It's probably not as fast as you want it to be because again, you're hoping to have probably a more straightforward case for Connect. What are you thinking at the moment? Are you thinking about converting? If the audience wasn't there, would you have converted? Talk us through that.
So no, I always try to stay, with Da Vinci approach for the entire case, unless I'm not making any more progress. But it's usually when, I find out that the tumor was invading other organs, things like that. But otherwise, I find that with this approach, I am even better than open. Open sometimes it's harder, especially in obese people. But I earlier in my learning curve, of course, I would have definitely opened this case, and also before I started doing my total robotic practice in 2020, if I had been doing this case laparoscopically, there's no way I could have completed it minimally invasively.
Yeah, got it. Yeah, it's I kind of tell myself this all the time. I was like, hey, listen, it's not going to be easier to open. So it's either if I make a move to an open case, something went terribly wrong, which actually I converted a case. It was like a 7th time redo pelvis. It was a lady for a pouch excision, and it was god awful. And I actually had to convert it to open, and we got it done. But I had to call one of my partners in. George Nassif had to come and give me a hand for the. We had to actually do convert the patient to an APR just to get the pouch out. It was awful. So it doesn't necessarily mean it'll be easier when you go open, but kudos to you, man. So walk us through. Is that the IMA there now? I'm getting.
Oh no, we're still lateral. Well, now we just went medial, and we are working
Okay.
to identify the. Oh, maybe there's a little bit of lag, but yeah, we are at 30 minutes of the live stream, and I'm trying to make a window around the IMA to be able to divide it.
Yeah.
And in this
the
case,
bleeding there.
yeah, a little bit of bleeding in the mesentery. So I'm gonna put I like to put surgical snow pretty liberally when I have this that are not being well controlled with my instruments.
Yeah. So what are you thinking about your plane at this point? Because obviously, we're always taught you got bleeding, something's not right. You're in the wrong plane usually. So what's going through your mind at this point?
I am thinking that at some point I might have to try to find another plane, but I don't know where, because here I'm already very very low on the dissection. So if I went any more lateral, I will be right on top of the right iliac. So I say, okay, let's keep going. We're making some progress. We already identified the ureter. We're switching to vessel sealer, so maybe this will help me have better hemostasis, bigger bites, as opposed to scissors. Whereas otherwise, all the dissection I would have done with monopolar scissors, blunt.
I was just about to ask. Okay, great.
Yeah. I think you used to use hook a lot, and then you switched to scissors, right?
Yeah, exactly. Yeah. It's funny. It was like let's do something like this, like reviewing one of my videos, and I only used hook just because that's actually what Lugaris used when I did my case observation with him when I had hair back in the day. I watched one of my videos and realized how barbaric I was being, so that's when I switched to scissors.
They work so well.
But
And
yeah, exactly. Yeah.
Here I switched to scissors to get a little bit more speed, and instead of having to bite and then burn and then cut and just go. Now thinking, okay, I already know where the ureter is, which is over here, if you can see my mouse. And so all of this stuff right here should be takeable, but it doesn't look like normal tissue. So it looks like it wants to bleed, but I'm going to try to take it anyway, and just try to mobilize this rectosigmoid area.
Got it. Okay.
I'm going to fast forward a little bit.
Okay.
Yeah, and I like this technique of spreading with my left hand and then going up above with the scissors and cutting in between my instrument, just like we used to
Yeah,
do it.
really nice.
Here, when one tip that I like to give is when we're working here on the left side of the pelvis, I like to grab the rectosigmoid area like I'm doing here with my number 2. And my number 1 and my number 4 are working. But when I'm going on the right side in the pelvis, then I change, and my retraction is with my number 1, and I'm working with 2 and 4.
Got it. Hey Diego, can you move your mouse so we can see the controls are blocking? There you go. Thanks, man.
Okay.
Yeah, perfect.
I'll play at normal speed now because I think we're about to find the IMA. And
Got it.
so
Super.
yeah, go ahead.
No, please.
So like we were like you were mentioning, Dr. Lagares was there. And here I think he's about to give his suggestion of switching the medial to lateral plane a little bit more to the right side. And that is one of the huge benefits of Intuitive Hub, that not only can you observe cases in real time from your office to any OR that has Intuitive Hub, but you can also interact live. And in this case, he gave me a suggestion, which ended up helping tremendously. Because right here, we're going laterally, trying to get rid of this tissue that is just so thick and indurated, and having a hard time making a lot of progress here. Fast forward.
This is still the lateral dissection right at the peritoneal flexion, basically.
Yeah,
Or above it, right in the pelvic inlet. Yeah.
exactly.
Yeah, this is scary stuff right there because you don't know, like, yeah, you found the ureter upstream from that, but who knows if it's stuck in there.
Yeah. And I was thinking all of this was desmoplastic reaction. So here is where
Yeah,
Dr.
yeah.
Garris, who is there. Oh, let me just, because this is, I think, very important. Okay, so here, Dr. Lagares makes the suggestion, you should go a little bit more medial on the medial to lateral dissection. So I said, here, he's like, yeah, there. Okay, let me do it then. So I pull that tissue up and start dissecting down there. And as you can see in a minute, it's going to be a little scary how close we are here to the right ureter, and which is right there, and the right iliac artery. So it's definitely much more medial on the medial to lateral dissection that we would normally go, but it is helping. We are finding a better plane here, and we are making more progress. So this made me a little bit more hopeful that I was gonna maybe finish the surgery in the 2 hours that we had. And of course here,
Yeah,
this,
it was remarkable. I mean, as soon as you made that incision, it's like this is the first time I think you've seen some sort of normal areolar tissue plane this whole day. I mean, it's scary. You don't want to see this plane ever, but at least it's normal.
yeah. Yeah, and at this point, I was not that interested in preserving all of the hypogastric plexus and things like that, but to get all the disease out.
Yeah.
Fast forward a
So
little
here
bit.
you've lifted up this basically this far lateral kind of medial approach just to the just a bit medial to the iliacs, and now you're approaching the presacral space now, right?
Yes, and we have this chunk of tissue that is mostly peritoneum and thickened areolar plane that we need to divide to be able to connect the two planes. We're at 60 minutes of the live stream, and here I was like, okay, and we have not even divided the IMA, but we are making progress, and we are very close to the right ureter there, as you can see.
Yeah. So
Yeah,
just
there
to
it
make
is.
sure my orientation is correct, you've had a medial plane that you started, and then you had a new medial plane that you began, and this new medial plane is what you're going to actually try now and join to the initial medial to lateral dissection.
Yes, and eventually, of course, to the lateral to medial that we had created.
Got
Um,
it. Got it.
so here, I think what I'm thinking is IMA, right? We need to divide this IMA, and once we divide it, we'll be able to make even more progress. And spoiler alert, but we were able to divide the IMA before we ended the live stream. So let's show that. So in this case, I mean, the question is, there are many options for dividing the IMA. What would be your choice to divide this vessel?
So I think in this case, I mean, you did you'll show it here in just a moment. The audience will see it, but you did such a good job skeletonizing it. I vessel seal everything. Having said that, I have out of, I don't know, either boredom or I'm just getting old and I like to do something different. Actually, I probably would have clipped that, to be honest with you. Just put two wet clips proximally, one distal and cut in between. Because you did such a nice job skeletonizing the vessel.
Thank you. Cutting with the vessel sealer, right? Even between clips, you can seal and cut once.
So no, I won't seal and cut just because I'm paranoid from the fuse course that I took for Sages, because the energy will travel down the clipped lumen.
And
So no,
dislodge.
I'll just sharp cut. Yeah, exactly. So I'll just sharply cut it.
We're starting
And
to
so here's that
see.
vessel. Why don't you mind slowing it down a little bit, Diego, just to make
Check.
sure that everyone can see it. So here you are, you're kind of infra IMA, you're skeletonizing coming around.
I think you
So
can.
yeah, talk us through your what you're thinking in terms of your division options here.
I'm thinking, so here we are around the vessel with the instruments. I like to do this with scissors. And then I'm like, this vessel definitely, I don't want to run into any bleeding. And in my opinion, this is the safest way that we have for dividing vessels, at least in my hands. White load, short form stapler. And I've been
Now,
getting.
do you always staple?
No, I staple, but I do staple more frequently than you, for example, or than many others. I staple about 30% of the time. If there's any question, if the vessel
Got it.
looks big, calcified, or in this case, it was desmoplastic reaction, I don't doubt it, and I use a wide load. And the mesh material
Okay.
is it's a staple and reinforcement that I placed on there. That helped me identify it.
Oh, got it. I was wondering what that was.
Yeah, that little piece of mesh there
So
is
this will be a good question for the audience. Yeah, I'd love the audience, and thank you, Lisa, for putting your preference in. I'd love the audience to kind of chime in. Tell us how you would have divided this vessel. Would you have divided it with a stapler like Diego did? Would you have clipped it like I may have suggested, or would you have done it with a vessel sealer? Yeah, just kind of chime in below. And also, I'd love to know who in the audience would have converted this case to robot to open at this point. I'm just curious because this is not an easy case. I mean, you're really thankfully you're progressing at this point. Okay, so IMA has been divided. You don't think you need to take the flexure down, so you're not going to do the IMV. So now walk us through your thought process at this point.
Yeah, at this point, I'm trying to connect the medial and the lateral planes, because once I do that, I can choose a point of division for the descending colon that I'm going to use for anastomosis.
Got it.
Yeah, so, and I know I already identified the ureter laterally on that plane initially, so I'm trying to, now that I have a better plane medially, to try to identify it this way too, and that way it's all connected.
Got it. So interesting. So some people in the chat real fast. Trey Moody would staple. Lisa Donaldson would have also stapled. And Jay Grove, Jay, help us out here. You say endoloop it. How would you endoloop this? Would you first divide, just sharply cut it and then endo loop, or what would you, or vessel seal that endo loop? So walk us through it, Jay, if you can. All right, so you keep this medial to dissection, kind of carrying it
lateral.
north.
Yeah, and then I believe I find the ureter from medial to lateral here, if I remember correctly. Yeah, I think that's it right there. With the psoas tendon behind it.
Got it.
Yeah. So that gives me some confidence that okay, we're in good shape. We're in good shape. We can still do this.
Yeah,
Of course,
exactly. That's like finally breathing a sigh of relief at this point.
yeah, and of course, with all this bleeding that I was trying to, I was trying to do a case with no bleeding for the streaming, and then we have all this.
Exactly. No, I mean, but the reality is, man, I think that most people in the audience, I think definitely the ones tonight, like we can, if I want to see an easy case, I'll go to YouTube. And if I want to see an easy case, I'm just going to go on some sort of whatever and just watch the stuff that's been highly edited. This is the real stuff because it's like, it's when the horribleness happens, how do you manage it? And even a seasoned surgeon like you took advice from a stranger in an audience and it actually really worked, which I think is super. I mean, that's probably the best part about this. I think we're all getting.
Yeah, I think that suggestion and the fact that I listened to it saved us a lot more bleeding, saved us
Yeah,
time for
yeah,
sure.
yeah, for sure, for sure, for sure.
Yeah, and here,
So I got okay. So let me ask.
yeah,
Sorry, let me just. I'm going back to the. So Jay Grove clarified he'll vessel seal then endoloop the stump. So Jay, I'll kind of do the same thing actually, but only when it bleeds. So maybe not the best time to actually be endolooping things. So have you ever been in that situation, Diego, where you take an IMA and it bleeds, and then you have to do something in reaction to, or what is it?
I have been in that situation, and I like to have the robotic clip applier ready and in the room,
Got it.
and
Got it.
I try to hold it, and then with my left hand, and then put the clip applier under it. But endoloop also, I have used endoloop as well, and it works as long as you try to keep control of that vessel. I saw the video you posted with the endoloop.
Which was this? Oh yeah, that was a disaster. Oh my God. Yeah, for y'all that don't know, Diego's talking about it. I had a case where absolutely beautiful skeletonization, if I have to say so myself. Really, it looked like a healthy IMA. I sealed it. Just the IMA stump blew out. And the takeaway from that was my FA is awesome. So she got an endoloop in there in no time, and then we got control of it. But I think in hindsight, I would have done exactly what Diego said. I would have just clipped it, and now I know to clip. All right, so set us back up here. So you've now gotten in the medial plane. You've communicated your let's call it medial plane 1 to now medial plane 2. The IMA is now divided. Now you're back lateral now.
We're back lateral, finishing up these attachments, and then we're trying to go into the pelvis here on the lateral wall, left lateral wall of the pelvis, down into the rectum, because we want to divide. I want at least 5 healthy centimeters of distal margin. And here we are at the end of the live stream. So we ran out of time. We streamed for 1 hour and 45 minutes. So this, from now on, is the rest of the story, is what happened after we finished the stream.
All right. So now you're coming on with your TME. Do you normally do TME with vessel sealer?
With scissors, usually. Yeah.
Scissors, got it.
And in this case, I
So
think
actually, yeah, real quick question in the chat. So Shrey Modi's asking, knowing pre-op that it's an obstructing upper rectal cancer with lymph nodes, and he's saying I would have done stent and ICG through this case with the robot, especially with the lateral mobilization and so on. So did you consider stents in this case? And it didn't seem like you needed it because you found out you hurt her. But I'm curious, what's your stance on stents?
yeah, very, very good question. So I never do. I don't know. I mean, I do when it's super difficult to identify, and just intra-op, I call the urologist and they float a stent real quick. I don't even have to undock the robot or even stop what I'm doing. They just
they'll do it in the operating, like while you're operating.
Yeah, they don't even tell me
You're
to stop what I'm doing. And then
no, you're all just our studs then. Yeah.
they use
No, it's
their
like a production at my hospital, man. We gotta call in a favor. Gotta get people to come in. It's a mess.
so you then in that case you must preemptively sometimes place stents because you don't want to run into that situation.
Yeah. So exactly. So for me, I'm highly selective when I get them. Like in fellowship, if you had something called a colon, you got stents. Everyone got stents when I was in fellowship. And when I get into practice, I couldn't find the ureter. Like at least I could, but like I had to get really good, really quick at finding ureters because to get stents, it was like literally calling in a personal favor. And so now I ultra selective with when we put stents in, and for me it's worked well. So if like patients with you know any sort of fistula to the bladder, I'll get stents just because I want to look at the fistula. And if it's like a multiply reoperative pelvis, then I'll get stents. Although I didn't the other day when I had a redo 7-time redo pelvis for a pouch excision. I should have got stents on her, but I didn't. She did fine though.
Yeah, but I was coaching one of the surgeons through a colon, and they did stents and injected. We placed ICG through the stents, and it was easy to identify. So that's a very good option.
Nice. Now you don't do the stents because Trey in the chat is saying that he actually got credentialed to play stents. So that's pretty great.
Yeah, that's great to be able to do it on yourself.
Yeah.
I don't know if the urologist.
Fun fact. Yeah, fun fact. I'll just drop this at the Orlando Colorectal Congress in Orlando, Florida this year. Just to let y'all know, we're running a cysto stent course. We'll get you fully credentialed. It's in November 6, 7, 8 is the Congress date. More to come on Surgeon. Shameless plug, exactly.
Yeah, no, I might
All right,
take
so
it.
talk us through where you're at now. You get hand in the presacral dissection now.
Yeah, here we are presacrally, going on the left side of the pelvis, just going down to an area of healthier rectum, at least 5 centimeters distal to the tumor. I'm not going to do a full TME. I'm going to do a selective TME, and leave him some rectum to work with, instead of making him go to the bathroom many times a day.
So let's talk about that for a moment. So this is an upper rectal cancer, and that is the reason why you did a tumor-specific mesorectal excision.
Correct.
Let's say it wasn't as nightmare-ish as this case. Same thing. You would have just gone just distal enough from the mesorectal dissection so you can staple, or would you have done like the mesorectal mobilization, but then only divided the mesorectum? You get the difference? You get the question I'm asking?
Yeah. If I do the dissection as if I was going to divide all the way down to the pelvic floor, or just a selective dissection, and no, just selective. Yeah.
Okay, got it. I'm curious if y'all can put in the chat as well what you all would do during these tumor-specific mesorectal excisions where you do not need to do a full-on TME. You're going to do a proximal or like upper mid-rectal dissection division. Do you go ahead and do a full mesorectal mobilization? I mean, I'll tell you personally, I like doing the full mesorectal dissection so that it's easier for me to decide on my division point, and it's easier to bring the stapler up. I mean, clearly you didn't need that here, but I'm just curious what the audience would do in this case.
Yeah, and that's a good point. And Mark, how I'm always advocating for shorter staple heights, and I have posted a couple of videos of me going to the upper rectum with a white load even.
Exactly.
In this case,
there's nothing. No. This guy needed like a what's larger than a black load? You need like like
no or something. I don't know.
Vessel loops, basically. This one.
Yeah. Well, thankfully here the green closed, but I had to reposition it for it to close. So the first try, it didn't tell me it was too thick. Repositioned it, took tissue out of the crotch, and then it's pausing for compression for the second time, and it's pausing for compression a third time now. And then it went to the rest of the part, which makes me feel comfortable when when the stapler pauses and then goes, because I know that
Yeah.
it was right for the tissue. So we're dividing
Yeah.
the rectum at 2 hours and 40 minutes from the beginning of the case. Second fire.
That's actually, man, you're still making good time, man. This is crazy. Oh, I just noticed something. Your bed's not tilted. You don't tilt to the right on your bed position.
Correct. I don't. I do almost always 25 of Trendelenburg, and I don't like to go steeper than that for, hemodynamic reasons, patient's comfort, unless I really need it. Like today's case yesterday's case, I went to 30 degrees, but yeah, I don't tilt left and right for some reason. I have not found it that helpful. Do you?
Yeah. I
Okay.
do. So I start. I'm I'm yeah. I'll just say it. No, I go 30 and 10. 30 degrees from Ellenberg, 10 degrees right side down. That's my starting point.
And what
And
do you see in that?
it really helps get the small bowel made. You're not having the problem here, it looks like. But usually it really helps get the small bowel way out of your face. And so I try to do I try to, my objective with positioning the patient right side down and Trendelenburg is to get the small bowel position in the right upper quadrant. And the intent is so that I can passively see the duodenojejunal junction, the INV, all the way out in the presacral space without the need for my first assist to touch the bowel.
Mm-hmm.
And I have found that anything less than that, in general, it's a general statement, of course, that typically there's a lot of interfacing, interacting with a small bowel that I try to avoid. But clearly, you're not having those issues in this case. You're having a lot of other issues in the case because of the disease, but not the small bowel.
Yeah, this small bowel cooperated, which was, imagine if it had been a math with a small bowel.
Oh my God.
I
Yeah.
would have probably
All right.
put it
So
up.
okay, you've done the distal division, which, man, I'm sure you have breathed a big sigh of relief. So
Yes.
talk us through now your mesenteric division. How do you strategize that? And how do you talk us through this part of the operation.
Yeah, I have my assistant, as you can see here, through the 5 mm assistant port, grab the specimen pretty much, because I like to work with two left hands and one right hand. So my assistant grabs to the right of where I'm dividing. That tattoo that you see on the colon up there is us with the tip of the marking pen with a laparoscopic grasper. I mark where I'm going to divide, right, tentatively, and then we check with ICG and confirm that that is the right spot. But when I'm dividing the mesentery, I go just proximal to the division of the IMA, and then follow that all the way to the colon where I'm planning on dividing.
Got it.
And I like to close off the specimen with an endo loop, especially when there's cancer, but it's also to avoid spillage.
Yeah, got it. Do you prep your patients?
Yeah, the patient is prepped with both antibiotic and mechanical bowel preps, and but as you could see there, the prep was not great, partially because of the partial obstruction.
Yeah. All right, so there's a question in the chat, actually. James Verlanik. James, I hope I didn't mess your name up. He's asking about the 60 mm staple on the pelvis. Do you ever have issues fitting it into the pelvis?
So it is challenging only in the very, very narrow pelvis. In the typical, even male pelvis, I have not had an issue, because if I can't do it right to left, I go either top to bottom or bottom to top. But I have very rarely, almost never, had to switch to a 45 mm stapler with this approach. What about you, Mark?
So I did probably, God, what was it? I think I was on my 600th case when the Sureform 60 came out. And so I just got used to using the 45s. So I just use 45s on the left, and now I use 60s on the right. and kind of because of what James is saying, like I had issues getting the 45 sometimes to fit in the pelvis. And actually, in fact, James, when I was with the what was it called? Whatever the previous stapler generation was called, it'll come to me in a minute. I'd actually started to use 30s when I was doing like a coloanal, just so I can get the angle right. But the Sureform stapler has a better articulating wrist, so you can really get it into a nice angle. So you don't need, so although the 60 is longer, because the angle that it can generate, it's much easier to actually get it into the pelvis.
Yeah,
But Diego's exactly right. It's sometimes usually it's not an issue, but deep in the pelvis it can be.
right, right. No, that articulation is key. Like I think it goes all the way to 60 degrees of articulation. Don't quote me on that.
Yeah.
It's great down the pelvis.
So we brushed over the intercorporeal anastomosis. Let's talk about that.
Yeah,
So you did, yeah. Talk us through intercorporeal anastomosis. Really nicely done.
thank you. I like to, so as I'm dividing the descending colon with the vessel sealer, which by the way, I go about 2/3 of the sealing cycle. I don't burn it all the way, and then I transect it. As I'm doing that, my assistant already knows to introduce the anvil for the circular stapler. In this case, since the colon was a little bit dilated, we're using the 31 millimeter circular stapler instead of the 29, but most of the time I use the 29, which is the blue one, the blue anvil. This was a yellow anvil for the 31 millimeter. And I'm doing a purse string 3/0 Stratifix barb suture, full thickness, and I'm reinforcing with a vicryl endo loop on the anvil. And then I leave the sutures long, as you can see there, because grabbing with my left hand on the suture, I can just guide it onto the spike, which is sometimes a challenging part of the case, is to grab the anvil, and you don't have to with this technique.
Yeah, got it.
So
So there's
most
a question in the chat.
Yeah, go ahead.
There's a question in the chat about how do you introduce that anvil?
Oh, okay. So anytime I do a sigmoid or an LAR, I start with a fan and steel incision and place a
Oh,
gel
got it.
point platform, and then I don't have to even open a 0-degree camera. I use the same 30-degree camera for the port
Makes
placement
sense.
for the gel point,
Yeah.
and then I can put a Raytech through there. I can put the anvil through there during the case without having to undock.
Got it. And as you brought your spike up, bringing it just through the mid part of the vertical staple line on the rectum.
Right. Yeah. Let
You
me
fashion
go
your
back
end to
to
end.
that part.
Yep.
Let's go back
And
to
now, do you always drain? Oh, you rewind over here. Okay, great.
I know I'm pretty much against drains except for when there's an abscess cavity, or where there's, in this case I was a little concerned. There was desmoplastic reaction. There was a lot of inflammation.
No. this guy had every reason to have a drain, two
Yeah.
drains, and a diversion. Yeah. Now, what about? I noticed that you reinforced your EEA fixation with the Stratifix. I noticed you reinforced it with an endo loop. Is that routine for you?
Now it is. I used to do it selectively, and then I had some incomplete donuts. So now I routinely reinforce with an endo loop, and I've always used the Vicryl. Some people like the PDS. I haven't tried that one.
Yeah. So I'd love the audience in the chat to chime in. Number one, do you do an intercorporeal left anastomosis? And if you do do it, how do you routinely do it? End to end, Baker? Do you sew it? Do you endo loop it? Talk us. Just put in the chat like how you actually do that. So Diego, about the intercorporeal anastomosis, just for a moment, is this your always kind of go to as an end to end, starting at the 12 o'clock position and then kind of working your way around like that? Is that your typical, or do you have different versions of that?
To sew the purse string, yes, I always do it like this. I start at 12 o'clock. I usually take 2 regular bites, counterclockwise, and then that third bite is usually the 6 o'clock area of the purse string, and I backhand it, so that's easier. And then the 2 or 3 other bites are forehand. and then I grab, and I can show you here because this I think is a good trick.
Great, yeah.
As my assistant dropped the anvil in, I'm gonna do the purse string, which I'm not gonna go over all of it again, but I want to show how we introduce the anvil. Okay, so there we go. Finishing up the purse string because I grab, and I want to know how you do it because you might have a better way. I grab at 12 o'clock, and my assistant already knows to grab at 6 o'clock, or in this case, I grabbed it at 6 o'clock with my other hand, and that way we
So,
stretch it.
yeah. Yep. Yeah, so the insertion of the anvil, identical. I tend to start. I love how you start at 12 o'clock and work your way down for the suture. I start my suture on 7 o'clock on the clock, so bottom left, and I go
Okay.
into out, and I do a running baseball stitch into out, into out. It all kind of all the way around the clock. But this turned out really, really nice how you did that, starting at 12 o'clock, and then you did it kind of as a running, basically like a running U stitch or purse string, if you will.
Right. Like, yeah.
I think Eric Haas calls it a dolphin stitch, something like that.
A dolphin. Yeah, and that's why I was a student with him, so that's
Oh, nice.
yeah.
So I always found that doing it that way tend to cause pleats at the edges of the at the end, but
Oh,
it doesn't really look like you're having that issue. Yeah, kind of like that, but I mean, even here it looks like it's mitigated and looks pretty nice. Anyway, man, really,
yeah.
listen, really, really nicely done. Really nicely done. So we're just about done. Actually, we're right at time, 1 minute from time. Any parting thoughts to the audience, Diego, for your for the experience that you had, all the stuff that you ended up going through.
I want to thank everyone that was there because it was a live case and I could hear what the audience was saying as I was operating on the console. And Lila was moderating, so she was kind of filtering some of the comments to me. But everyone was so supportive in the audience, and everyone was saying, "Hey, keep going! You're doing great." I would have already converted, and so kudos, and that really helped
Yeah,
me.
yeah, no, that's awesome. Obvious question: how's the patient doing?
Okay, so he went home on post-op day 2. I did divert with an ileostomy. And he went home on post-op day 2. It's 4 weeks out now, exactly 4 weeks out. I saw him Monday, and he's doing great. He's having a little bit of issues pouching the ileostomy, and he wants it gone. But
Yep.
we're gonna get, and I want to, if we have time, or maybe later in the chat, what would the recommendation be for post-op radiation or chemo, or one or the other? Because the pathology and okay, I don't think we have time to show a couple of slides for the pathology, but it showed a lot of tumor deposits in that mesentery.
Yeah.
About 10 out of the 30 lymph nodes were positive.
Jeez,
The,
yeah.
the mucosal margin, the colon margins were distally, we were clear by 7 centimeters, proximally by much more, but the mesenteric margin was a positive margin on that.
Oh, yeah.
Yeah. So
Yeah,
yeah,
that's awful.
you're gonna need some
Well,
pre.
I'll tell you what, yeah, why don't you, I think that'd be a great conversation for us to continue to have in the chat. So if you don't mind, Diego, maybe post that path or post the images or the slide that you prepared for that in the chat, or right after this, just post as an image, as a comment,
Yeah.
and we could just continue offline. So listen, Diego, awesome, absolutely fantastic, lots of really positive comments. I think the nice thing about the colorectal surgery community, and really in the kind of this robotics and Da Vinci community and the surgeon community, is I think we kind of become this there almost becomes a little bit family-like. So we felt you doing this thing. I wasn't there, but I kind of felt you suffering through it. So I think we all feel the same way. This is an absolutely fantastic experience in retrospect that you're able to share with us. This is a real case. Thank you so very, very much for taking the time tonight. Thank you to the audience for that as well. Abby, we'll kick it over to you.
All right. Thank you so much, Dr. Marinas and Dr. Soliman. That was really engaging. I love that there was so much going on in the chat, a lot of back and forth. I think we hit our goal of making it very interactive. So that was really nice. To the audience, just to remind you, this webinar will be available for the next 90 days. So you can revisit any key moments. Diego is going to put a couple updates in the chat for us. Or you could share this with some colleagues that weren't able to join us and you think could benefit from it. But if you're thinking about what's next, I know this slide's been up for a minute. We have an exciting event lined up for you, which is our morning symposium at ASCRS on Saturday, June 1st. If you'll be attending ASCRS in Baltimore, we invite you to join us for our Da Vinci Colorectal Symposium. You can go ahead and pull out your phones, scan the QR code, and register to secure your spot. And at the symposium, you'll have the opportunity to dive deeper into engaging and informative presentations from the experts that you see here on the slide. But there's something equally or even more exciting, which is that we are thrilled to announce the launch of DV5 at ASCRS, a true transformation in surgery. You'll have the opportunity to experience the system firsthand by visiting the Intuitive booth in the Innovation Hall. We can't wait to connect with you in person and answer any questions you may have. So we'll see you there at the booth. And with that, I'll close out the webinar. Thank you so much for your time and have a wonderful night.